you can actually have some really nice phenotypic results.
And what's important is that he's not going all the way to the bone. He's leaving the periosteum underneath.
So depending on what you're trying to achieve, whether it is a full thickness, mucoperiosteal, or partial thickness, mucosal, you dictate what the outcome's going to be. You basically have to ask yourself, what are you trying to achieve? Are you doing a socket graft, connective tissue graft, free gingival graft, maybe a VISTA technique or Zucchelli? Are you doing a crown lengthening or guided bone regeneration or maybe a biopsy? So with all this in mind, you need to ask yourself why you're doing it and what design would best fulfill what you're trying to achieve, right? So in this particular case, I can't remember, I think I'm doing I'm placing a fixture after this. So this is a healed open membrane technique socket, and I'm placing a small fixture. I could have punched it, I realized that, but I decided not to punch it. I decided to make a small micro incision and just place my implant that way. And then I wanted to take that flap and reapproximate it buccolingually to the healing abutment, because I wanted to utilize that beautiful amount of keratinized tissue that healed, that came about as a result of that open membrane technique. So why waste it? And if you do it right, if you manipulate your flaps and you respect your biology and you suture it right, you can actually have some really nice phenotypic results on your gingiva and your gingival-alveolar architecture. So that's what I'm trying to encourage to you. Really, it's up to you. It's up to you to decide what you're gonna do.
Number one is a thickened keratinized gingival mucosa, very thick, okay, band of keratinized tissue, and more importantly, deepened vestibule, okay. And that's going to help not only for the natural dentition, but you saw my presentation on the lower 2 implant supported prosthetic is also going to be a contributing positive factor to the long-term survival of implant. Okay, so yeah, okay, so free gingival grafting was something that I used to do a lot in my early career, and I abandoned it because I didn't really see the importance until a few years ago. I started to see that the benefit of a FGG, free gingival grafting. So these days I do it quite often, and it's one of the most predictable soft tissue grafting that you can do if you learn properly. Okay, so I highly recommend the advanced soft tissue course that we'll be running with Dr. Jeff Lee next year. He's a periodontist from Toronto, so we're excited to have him. So here is a 2-day workshop. He's going to cover FGG and CTG, both, because you really need to know how to do both, because one indication is different for the other. Okay. All right. So good. So what he's doing is he's scoring right at the mucogingival junction, and what's important is that he's not going all the way to the bone. He's leaving the periosteum underneath. Because when you do FGG, your major blood supply comes from the underlying periosteum, okay? Whereas the connective tissue, the major blood supply comes from the overlying mucosa, right? So when you're doing a connective tissue grafting, you can raise a full thickness and you can have still a very successful outcome. But FGG, you do not want full thickness, okay? You need to leave enough periosteum attachment underneath it so that you can suture the graft to the periosteum.